Hi, Dr. Janice Huntingford here again, and we have a three-part series on neurological rehabilitation. And I have to say that neurological rehabilitation is probably one of my favorite things to do. So I hope that in teaching this to you that you will enjoy the results of taking these dogs who can't walk and getting them to learn to walk again. So our objectives for this part one of the neurological rehabilitation are we're going to review the anatomy. We are going to go over the neuro exam, and we'll learn how to localize the lesions. Now, I do know that when I was in veterinary school, that neuroanatomy in general was not one of my favorite topics, and in fact, I didn't even like neurology. But the more that I have worked with this and learned it, it makes absolutely perfect sense to me now. And I am hoping that it will to you as well. Now, neurological cases, as I said, they were not my favorite in veterinary school. In my first years of practice, they were not either. Because what I find when I speak about neurology and when I teach veterinarians to use neurology, that many times they identify a case as being a neurological case and they realize it's very difficult to manage and they would rather throw up their hands and send the patient to the neurologist rather than deal with that themselves. But what I will be able to teach you is to know when to send your patients to the neurologist, because there is time to do that. And if your client absolutely does not want to do that, then what do you do? And we don't give up, we just have other plans. So when we are dealing with neurological cases, we need to remember that we are normalizing tone, we're looking at proprioception, and we are trying to optimize function. Rehabilitation is always about optimizing function. Whatever the structures are there, if they are broken, if we have a fractured spine, something like that, then we let the surgeons and neurosurgeons fix that. And what we aim to do afterwards is take this dog who is not functioning well, not walking well, not having good neurological function. We take that dog and we get it as back to normal as we can. And to do that, there are some very specific exercises that we will learn in this course. And there are many modalities that we use, many things that are needed for functional recovery. And I have to say that a lot of the neurological exercises that we do and a lot of the neurological modalities have come from physical therapists treating human stroke patients in particular. And not just strokes, but other things, brain injury, and post-car accidents. So many of the things we've taken from human medicine and we've adapted them for use in our veterinary patients. One thing that I do want to stress, and hopefully by the end of this whole course that you will have gotten from Dr. Ron and I, is that diagnosis is very important. I mean, there are times when we can't do advanced imaging, but diagnosis is very important. And why is that? Why can't we just take a dog with a neurological problem and say we're going to rehab it? Well, that's because many times when we look at these cases, it makes a difference as far as the prognosis goes. So we're really looking at diagnosis, driving treatment, driving prognosis. So here is here's one of our spinal units. Obviously, it's an intervertebral body, and you can see the caudal articular process. So here is our vertebral body, and up here we have the caudal articular process. We need to remember that each vertebrae has in it its own intervertebral disc, and this is basically our unit. But it's important to remember where the spinal cord lies, where the disc lies, and that way we can have some idea of what's actually going on. So with this, this is of course our bone, all of our vertebrae, with all of our processes that interact with each other. And right below that is the spinal canal, and of course it has our spinal cord in it. And you can see that we have our gray matter here, and on the outside we have our white matter. And this is an important thing to look at, is our dorsal longitudinal ligament. The dorsal longitudinal ligament sits there below the spinal cord, and that is one of the things that can become mineralized, and that we can see that. And so the idea is that if we have problems with our dorsal longitudinal ligament, often that is going to put some pressure onto our spinal cord. And down here, of course, we have our intervertebral disc, and it is composed of the nucleus pulposus and the annulus fibrosus. The annulus fibrosus being here on the outside, and the pulposus being on the inside. So that's really, and of course the ventral longitudinal ligament is down here. It's important to keep in our minds how this looks as we go through, particularly dogs who have spinal cord disease. And then we have an idea of what's going on with them. So this slide shows us the upper motor neuron and the lower motor neuron pathways. And sometimes this can be confusing. We all learned this in veterinary school, but it's very important for rehabilitation to know what is the difference between the upper motor neuron and the lower motor neuron pathways, because that drives treatment and that drives prognosis. So let's review that here. What we need to remember is that the upper motor neuron lesion is in the neural pathway above the anterior horn of the spinal cord, or the motor nuclei of the cranial nerves. And that our upper motor neuron cell bodies are all here. So the upper motor neuron runs, like this, and has a couple of intumescences here. But their cell bodies are in the brainstem and the cerebrum. Whereas our lower motor neuron, the neurons are going to directly innervate the muscles. And all of the cell bodies are located in the ventral gray matter of the spinal cord. So those are important things to remember. Now here we have a look at our spinal cord, and we have the different little spinal tracts, and it's not important to remember what the names are of these spinal tracts. But here's the important thing to remember. If your tracts run dorsal and lateral, those contain the sensory and proprioceptive, the proprioceptive and sensory tracts. So these are the dorsal tracts and the lateral tracts. And those ones, if they are damaged, what we will see is that the dog is ataxic. So our dog is going to be wobbly, and the dog is going to be ataxic. However, our ventral and lateral tracts are going to be motor upper neuron. So if we have damage to the ventral and the lateral tracts, these guys here, then what we are going to get is paresis. So you can see from here that if we're damaged up here, we're going to have just ataxia. But if we're damaged down here, we're going to have paresis as well. And the cell bodies of the lower motor neuron are in the ventral horn gray matter. So this is right by this little green thing. That's an example of ventral horn gray matter. And if that area is damaged, then we're going to have lower motor neuron paresis. So hopefully that is clear. So let's summarize this in a way that might be easier to understand. You need to think about the upper motor neuron as telling the lower motor neuron what to do. It stimulates or it inhibits the lower motor neuron. I like to think about the upper class as having servants. So the upper motor neuron is the one that tells the lower motor neuron, the servants, what to do. And the lower motor neuron has to have direction from the upper motor neuron. So it receives input from the upper motor neuron. And the lower motor neuron, remember, is the one that connects the CNS with the muscles. And this is very important. It is responsible for spinal reflexes. Now, our upper crust, our upper motor neuron, that is the thing that tells the lower motor neuron what to do. So what does that mean? It means it's the one that initiates voluntary movement. So it's going to initiate voluntary movement and maintain our muscle support against gravity. And it's our upper motor neuron system that regulates posture. So if you're having a little bit of trouble wrapping your head around that, have a look at the slide before and spend a little time looking at this, because that's going to be helpful for you. Now, when we look at spinal cord disease, a lot of times people are confused about what is really the difference between ataxia and paresis, and I will write some reports that say, the animal has non-ambulatory function, and I will talk about paresis and if it's non-motor, but and ambulatory, non-motor, and people get very confused with this. So we'll go over many of these terms so that we're all on the same page and we understand them. So ataxia and paresis are not the same. Ataxia is really loss of coordination, and this is going to occur when we have sensory dysfunction, and proprioceptive ataxia is probably one of the more common ones that we see. Now, paresis, on the other hand, is weakness, and paresis is weakness, motor dysfunction. It means that you absolutely wish to move, but you can't initiate motion. It has a lack of strength, short stride, weakness, and you can have upper motor neuron or lower motor neuron paresis. So remember, we can have that versus that. And we'll talk about the difference between the upper motor neuron and the lower motor neuron paresis. So when we have spinal cord disease, we have things like gait abnormalities, and we'll have neurological deficits. And we have some that are very specific and only occur with spinal cord disease. And if we have gait abnormalities and neurological deficits, those only occur with spinal cord disease. Something like a brain disease, like meningitis, is going to cause pain and certainly stiffness, but it doesn't cause paresis and it doesn't cause ataxia. It's important for us to remember that the spinal cord itself has no pain receptors. So if we're dealing with meningitis, it's going to be painful because of the surrounding structures. The ones that we looked at in that first slide, those are the ones that have nerve endings. But intrinsic spinal cord disease, such as degenerative myelopathy, is not painful because there's no receptors in the spinal cord. So here's a few other things to remember about spinal cord disease. That the spinal cord and the vertebral column are not the same length. And we need to remember that the spinal cord ends at L6 in most dogs and L7 in cats. So if you are doing a caudal epidural in a cat, then or in a dog, then you are past the end of the spinal cord. You don't need to be worried about that. You do have to deal with the cauda equina. The spinal cord controls bladder function, and bladder function can be either upper motor neuron or lower motor neuron. And that's something that we'll talk about in a later lecture. But in general, our spinal cord is divided into 4 functional parts. We have C1 to C5, which is going to be up here, and that's going to be all upper motor neuron. We have C6 to T2, which is here. That's going to be lower motor neuron. Then we have T3 to L3, and that's going to go all the way from here to here. Again, that's upper motor neuron. And then anything that's after L3 is going to be lower motor neuron. So this will help, we'll go over this a little more, but this will help us in trying to determine where we are in the spinal cord as far as the lesions go. So here's a good question. On our rehabilitation patients, why do we want to do a neurological exam on them? Well, I think the reason that we want to do a neurological exam is because we have to differentiate between neurological and orthopedic causes of gait abnormalities. So let's look at this dog here. This is a 9-month-old St. Bernard who came into me. And if you look at him, you need to think in your mind, is this an orthopedic case or is this a neurological case? And I'll play this video again. So is this an orthopedic case or a neurological case? He actually came into me for bilateral hip dysplasia, and you can see he definitely has a gait that might be consistent with a dog with hip dysplasia. So here's an interesting thing. I could simply say, fine, this dog was referred to me by a surgeon for hip dysplasia rehabilitation before having a total hip. And I could simply say, that's great, here's what we do, here's our plan for hip dysplasia. But you always want to do a complete neurological exam. So we'll go through how to do that, but I'll let you know, here's a spoiler, with this dog, I did a complete neurological exam on this dog, and he had positive crossed extensor reflex in the front and in the back. So that told me that he had a lesion somewhere between C1 and C5. So what this dog actually had was Wobbler's disease. He did have hip dysplasia, but he also had Wobbler's disease, and that meant I had to have a discussion with the client and say, are you sure you want to go through with doing a total hip on this dog? Because he also has neurological disease. And this dog had an interesting ending, and I think further on in the course I have other videos of him, so you can think about that. But you can believe that the client was very surprised to find out his dog also had a neurological disease which was likely to become more important for his life, and it did, than his hip dysplasia. And so it lets us know about prognosis. What is the prognosis for this dog if it has Wobbler's disease versus if it only has hip dysplasia? Well, if it has hip dysplasia and no neurological disease, the dog indeed could have a bilateral total hip and go on and live a perfectly normal life. Whereas with Wobbler's disease, it usually requires surgery in these dogs and can be a really long, ongoing process, which it was with this patient. So this is our little examination review, the neurological exam review. These are all of the things that we're going to look at. Mentation and behavior, attitude and posture, gait and movement, cranial nerves, postural reaction, spinal reflexes, pain on spinal palpation, and pain perception. Now, we are not going to use the great big long forms, the 6-page forms that you used in veterinary school, but I do use a neurological form. It is, however, abbreviated, but I am looking at all of these things with all of my patients, and it really doesn't take a huge, long period of time to do it. So, what are we looking at when we think about mentation and behavior? Is the dog normal? And I've put the definitions here for you because I know when I was learning things like obtunded, what does that mean and where does it go? Well, these are really the definitions here. So we're looking, is the dog normal, obtunded, comatose, or does it have some other problem? So if it's obtunded, which really just means reduced response to the environment, is this a mild problem? And mild is sometimes the clients just think the dog is lethargic or maybe it's a little bit sick. But what it really has is a mild decrease in response to auditory stimulation. If it's moderate, it's going to be still responsive to voices, but the response isn't going to be normal. So you might have to really clap your hands more, or to really get this dog's attention, you really have to do a lot of different things. So it might know its name, but you may have to call its name louder. If it's very severe, then these patients generally are not ambulatory. They may be responsive to very loud noises or very loud hand clapping, but they're not super responsive. So just remember, if they're obtunded, it's a decreased response to the environment. If they're comatose, well, they're unconscious and you can't rouse them with any stimulation. And then the other behavioral changes you can talk about: compulsive and agitation, aggression, dementia, those things. So that's your mentation and behavior. And don't forget, when the patient is coming into you, they are coming in and you're looking at them and you're assessing the mentation, the behavior before you're even touching them, okay? You're also going to assess attitude and posture. Attitude is the position of the eyes and the head with respect to the body. And so this issue is most evident in conditions like head tilts and vestibular disease. And if they have this, you need to think of brain problems and maybe some cranial nerve issues. Posture itself is going to be the position of the body with respect to gravity, and posture is much more often associated with spinal cord problems. So here we have posture and gait. So posture is going to describe your animal at rest. So if I have a patient who comes into me and they're coming in for a pain, maybe a disc problem, they're walking around on my exam floor, or they're walking around in my gym area because I've got great flooring there and that's what we want. I'm going to have a look at them and say, okay, this dog is interested in his environment. Obviously his mentation, his behavior is normal. But I notice that he looks like this dog here, where he has a dorsal curvature of the spine. And so this, of course, is kyphosis. This dog, as you can see, is missing a limb here, but this was a very good example of kyphosis, which is going to be the dorsal curvature of the spine. Now, lordosis would be the opposite, would be ventral curvature of the spine. We can also look for things like head tilt, head turn, head and neck turn, base wide stance. But as we were talking about, head tilt and head turn really are more cluing us into brain things, right? Base wide stance definitely can clue us into some neurological issues. So these postures are going to be abnormal. They're always abnormal, and many times they're quite rare. So if we have decerebrate posture, where we have extension of all the limbs, or we have decerebellate posture, which is going to be extension of the thoracic limbs and flexion of the pelvic limbs, or opisthotonous, which is going to be our dorsal flexion of the head and neck, and our Schiff-Sherrington, which has increased tone in the forelimbs and paralysis in the hind limbs. So these are not very common, but you might see them, especially after trauma. This is where we see a lot of these, but they're not very common. It's important to know that it is possible to see them. Now, from a rehab standpoint, what are we really looking at? Well, most of our patients, we're assessing things like, does the dog have a roached back, which is probably going to indicate a mid-spinal lesion, a spinal cord disease. What happens if the head is low, has a very low head, a front-end posture? Well, that's going to tell me that the dog very well has cervical problems. And then how easily do we push this dog off balance? That tells us. Is the patient standing with one leg extended or dragging, or is there obvious bilateral muscle atrophy that's going to, clue me into being disuse or neurological? So when we assess gait and movement, we assess both in the exam room and also in an area where we can walk the patient really well. I have a gym floor that I'm going to use. Outside is great, especially, if you're in Florida or somewhere where the weather's nice all the time, you can take them outside all the time. I take my dogs outside in the summer. Occasionally I take them out in the winter in the snow, but stairs are really a good thing to help us know about gait. And then we need to think about what kind of gait abnormalities are we having. Is it ataxia? Is it paresis? Is it a mixture? Is it weakness? These are the things. So we want to sort of start thinking about looking at these patients and putting some of these labels on them. So how do we describe gait? Well, I describe gait as either ambulatory or non-ambulatory because that's the easiest way to start. So an animal can be ataxic, but if I'm describing the gait, they may be an ambulatory patient that is ataxic. Obviously, a non-ambulatory patient is not going to be able to be ataxic. But I think that ambulatory and non-ambulatory is pretty self-explanatory. So here's, as I was saying, we need to, before we touch the patients, we need to watch them walk. And we need to think about using things like a video camera, maybe a lameness score, a neurological score, and saying, does this patient have paresis, or does it have ataxia, or does it have both? Does this patient have an orthopedic problem? Does it have a neurological issue? These are things that we need to consider when we look at these patients and when we watch them walk. Remember, true gait analysis is really done by a force plate or a pressure walkway, and we don't necessarily need to do that, but we can learn an awful lot with our hands and with our eyes. So how about ataxia? Because we talk about ataxia a lot in neurological rehabilitation, and I kind of break it down to these three types. Proprioceptive ataxia, which is going to be symmetric. We don't have any coordination, and often this is the first form that we see, and it's going to be quite mild. And then we have the other two, vestibular and cerebellar ataxia. With vestibular ataxia, it's generally asymmetric. So this is how we differentiate the two often. And the patient's going to drift or fall to one side. I just put this in for metronidazole toxicity because sometimes it's a mix of these two, including ataxia, and I've seen that, and I wanted to bring that to your attention. Cerebellar ataxia, again, is going to be symmetrical. I'm sure we've all seen these cats who have cerebellar ataxia, and where they have loss of strength in their limbs and a very bouncy gait, and they're hypermetric. So it's important when we look at these patients and we say they're ataxic, where's the ataxia located? So here's a few other thoughts for you. If you have ataxia without paresis, you're going to think cerebellum. And the ataxia can be so severe that the patient really can't walk, or at least not walk very well. If you have paresis without ataxia, it's going to be suggestive of a diffuse neuromuscular problem. So a myopathy, polyradicular neuropathy like Kuhn-Hound paralysis. And if you have paresis in the pelvic limbs without ataxia, then we also see that in lumbosacral disease. So have a thought about this particular slide and maybe make a few notes for yourself if you're not used to looking at neurological things, and kind of go on from there and think, okay, when next time I see a patient that has ataxia, how do I classify it? And is it walking or not? Does it have paresis or not? But I would say this particular condition here fools many, many people. So here's cerebellar atrophy. So this little dog has ataxia, but he's not paretic. That's a genetic problem in these little Jack Russell Terriers. But he's really, as you can see, he's really quite ataxic. So, and this is paresis without ataxia. So this dog is really just stiff. This was an early case of Kuhn-Hound paralysis. I mean, he really is quite stiff, and he's having problems, but he's not ataxic. He's not falling over. And this is another case of paresis without ataxia that's all often seen with lumbosacral disease. So he's not ataxic, but you can see that his gait isn't correct, and he's dragging his feet a little bit. So those are just little things to think about. So what tests do we use for ataxia and weakness? Well, we can use hopping, and that's easier certainly with very small animals. It's hard sometimes to hop a big dog. We can use cavalettis. We can walk them up and down stairs to see if they're able to do it. I like to use weaves and circles, because if we have a dog who is weaving and circling, then we're forcing them to weight shift, and a lot of times we can then see the weak limb, or we can see ataxia that way. Rhythmic stabilization is an exercise we use where we would put our hand on one side of the pelvis and sort of see if we can push the dog over. This video is of a boxer that has a proprioceptive ataxia, and it's in slow motion, so you can see he's dragging his foot there, and as he goes around the cones, he really has an issue going and standing straight. So here are more movement or lack of movement terms that I think are important for us to know. And they're very important that we understand what they are, and if we send a report home to the referring veterinarian or to the client, that we are using the proper terms. We can't just say the dog can't walk in his back end. Well, that really doesn't tell me an awful lot. So we need to think about paresis and pelegia. Paresis is reduced voluntary motion, whereas pelegia is loss of motor function. So you can have mono, hemi, para, and tetra, either paretic or pelegic, depending upon what's involved. And with paresis, there's always weakness. Okay, so this is the thing. With paresis, there's always a certain degree of weakness. And the weakness can be neurologic or neurogenic if the lesion is located in the peripheral nerves or in the central nervous system, or it might be true muscular weakness that you're going to see with something like Kuhnhound paralysis. Discombobulated or two-engine gait, I have a video of that. That's the dogs who are short, choppy in the thoracic limbs, long-strided in the pelvic limbs, and then of course we have knuckling, stumbling, or falling when walking. So here's our two-engine gait. See, definite difference in the back versus the front, and we're going to see that with spinal cord lesions from C6 to T3 can cause this. Also, lumbosacral disease can sometimes cause this. So what about cranial nerves? Because we should really start with doing a cranial nerve evaluation. And it doesn't need to be a long, involved thing. And you pretty much need to have a pen light, and you need to have a cotton ball perhaps, and a Q-tip, and your hands. And that pretty much is all you need to evaluate cranial nerves. We need to remember that our cranial nerve evaluations are either going to be reflexes or reactions, right? And the responses are going to involve either the afferent or the efferent pathways or the cerebrum. Now, I remember learning in veterinary school some mnemonic that, told me which was afferent and which was sensory, and that's kind of interesting to know. Not quite as important as far as when you're figuring out what's going on with these animals for rehabilitation. But we do need to remember that our reflexes involve both cranial reflexes and spinal reflexes, and they can involve our sensory afferent peripheral nerves or the cranial nerves, or they can involve the interneurons. So we can have these guys, peripheral nerves and cranial nerves, or we can involve interneurons in the spinal cord, or efferent motor neurons. So those are the three areas that all need to be intact if we have normal cranial nerves. So here's our 12 cranial nerves, and obviously we don't all MRI our patients, but sometimes if they have a cranial nerve problem, they need to go for a CT scan or they need to go for an MRI. But these are the 12 cranial nerves. In general, the first cranial nerve, the olfactory, is not evaluated. We don't know how well dogs are smelling or if they have a decrease with that. There's no way for us to evaluate that. But we often do evaluate the optic nerve, and then the 3, 4, and 5, a lot of them, 3, 4, 5, and 6 can be evaluated together, as can the facial nerve. And then, of course, we have things like the glossopharyngeal and hypoglossal, which have to do with how well is the tongue moving. And so these are sort of the ones that I'm going to use. I'm going to do a menace test, and that's going to check cranial nerve 2, nerve 6, and nerve 7, right? And then I'm going to check a palpebral, which is really cranial nerve 5 and nerve 7. And other cranial nerve tests that I'm going to do are a corneal, which is really going to check nerve 5, the auricular, where you basically take a Q-tip and you touch the dog's ear and see if it twitches, that's going to be 7. Obviously, pupillary light response is going to be 2. And this dog is really being checked for physiological nystagmus. And it's easier if you open the eye and look at the sclera to check for nystagmus. And nystagmus, we're going to really be checking these 4 here. So if we go through and we do those few tests and we come up with an abnormality, then we have to try to figure out, do we know which nerve it is? Is it really 3? Is it really 4? And then at that point, I would pull out my neurology book and have a look. I mean, I'm just really looking to see, does the dog have facial paralysis? Does it have asymmetry? And if so, I mean, I own a couple of neurology books, and I paid a lot of money for them, so I think that I would be able to take them out and look for them. But the real important thing is that you remember to do the testing. That's the big thing. So, what about the hands-on part of our neurological exam? We talked about the cranial nerve. We talked a little bit about proprioception and postural reactions. And obviously this is a conscious proprioception test. I'm taking the dog's foot and I'm putting it down and I'm trying to see whether the dog replaces it or not. Now, in dogs that don't like their feet touched, sometimes this can be a problem. And here's a quick little trick that you can do. I call this a sliding test. You can put a piece of paper under this foot and you have the dog just stand on the piece of paper. And then it's the dog standing there, and then you pull the paper this way. Because when you do that, you're making the foot go backwards. And a normal dog should feel his foot going back and should immediately replace it. Whereas a dog with neurological disease is going to leave the foot like this. And sometimes that's kind of just a trick that you can do. Spinal reflexes, these are they here, myotactic reflexes, flexor reflexes, dermatones, panniculus, we'll talk about those. And then, of course, spinal palpation and pain perception. This is a very good chart that I have reproduced in my clinic for the use of my interns and students and residents because it's important to know what goes first and what comes back first. Because sometimes, they miss some of these earlier stages and the clients miss them too, and we don't see them till they're here. But what we need to remember is that as spinal cord disease particularly progresses, that this is what we see first. So if you have a dog who the only thing that we're noticing is his conscious proprioception is a little bit off, then he's way up here. But now this actually happened to one of my receptionists. She took her dog on vacation and she had noticed that he was having a little bit of proprioceptive deficits. But he was a little bit off. And then within 24 hours, he was ataxic. And then she sent me a text because I was on vacation and said, my dog can no longer pee. I'm thinking maybe I need to get it in for some acupuncture. And this was all within a 24-hour period. And so I said, you need to take the dog to the emergency room right away because your dog's having a problem that's progressing very quickly. And she said, well, I pinched his feet and he still has pain. I said, that doesn't matter. That's good. But I said, you need to take him in. And he had a T13 L1 bulging disc and required spinal surgery. But these are the things that you need to think about is how does this progress? And I do have this discussion with all of my clients, especially if we're treating spinal cord disease medically and the dog's coming in and it only has some pain and maybe a little bit of proprioceptive deficits. If it's progressing quickly, run, do not walk to the nearest ER. So proprioception, again, tested by hopping and paw placements. We talked about that. In cats, you can wheelbarrow them because this is an important thing to know. Remember that with this, we're testing the forebrain, the brainstem, and the spinal cord. And proprioceptive deficits are very, very early. So if that's the only thing you're picking up, that's very early neurological disease. Now, the thing is, it is a good indicator of the presence of neurological disease, but it's not always useful to differentiate spinal cord from brain disease. Many times it is, but not always. So let's look at our spinal reflexes and how they work. The three that I will check all the time, although there are very many other reflexes to check, but I like these three: the withdrawal, the patellar reflexes, and the crossed extensor. Because of all of the reflexes that you are going to get, that are going to be you're consistently able to get them, the withdrawal reflex in the front and in the back should be consistent. If you do not get a withdrawal reflex, there is a problem. Now, the patellar reflex, as you know, is also sometimes called the quadriceps reflex, and that's checking your femoral nerve, whereas your withdrawal reflex in the back is checking your sciatic. And then crossed extensor, I have a great video of that in case you don't know what it is, but the crossed extensor really is the one that I use to differentiate upper motor neuron and lower motor neuron disease. I'm using reflexes to differentiate spinal cord versus neuromuscular disease, but here's something that I think people don't think about much. The patellar reflex can be physiologically absent in older dogs, but it's going to be symmetrical. And also post-stifle surgery, particularly post-TPLO. So you don't want to say, oh my God, this dog has a terrible neurological disease and it just had spinal surgery. So anyway, so the other thing that I have starred down here, withdrawal reflex does not equal pain perception. I'm going to show you that. So withdrawal reflex and nociception are not the same. So if we pinch this dog's foot, and he has withdrawal and nociception, you should be able to pinch his foot and he's going to look at you and go, what the heck are you doing? So here we get our little guy on the side here. He has spinal cord disease. We already know that. So we want to see about withdrawal. He goes, wait a minute, what are you doing to me? So that dog can feel that. Now this other dog, let's have a look at this. Withdrawal and nociception are not the same. So this dog's getting great withdrawal, but, he's just kind of laying there. He's not interested in lifting up his head or doing anything at all. And she's pinching his toes with a hemostat. With our friend Buddy in the other slide, if we'd used a hemostat, he would not have been very happy at all. But so this is just to remind you, withdrawal and nociception are not the same. And I think that's one of the biggest things that I see with my students is that they think they are. So here, I told you that I use crossed extensor reflex a lot to differentiate upper motor neuron and lower motor neuron issues. Now let me tell you with this, crossed extensor is an upper motor neuron reflex. So if the animal has a lesion between the first and the fifth cervical vertebrae, or the third thoracic and the third lumbar, T3 to L3, they have a T3 to L3 myelopathy or C1 to C5 myelopathy, then crossed extensor will be positive. Why is that important to know? Well, if that involves something else, then the crossed extensor won't be positive. But this is the test that I'm using in the front legs a lot of times to determine if my large breed dogs have wobblers. Because the only thing that crossed extensor is always abnormal, and the only thing that's going to give you a crossed extensor lesion in the front legs is something between C1 and C5. So let's look at this. This is a cat, actually, that had atlantal axial subluxation. Wow, isn't that a great reflex? So you need to remember that how this works. Why does this crossed extensor work? Well, the crossed extensor reflex is normal if you're standing up. It means that you can put all of your weight on the opposite leg. If you pick up one leg, all the weight goes to the opposite leg. That's a normal thing. That reflex should be inhibited when you're lying down. Otherwise, when you're lying down in bed, if you flexed your one stifle, your other leg would shoot out and kick your partner, and that would not be a good thing, and that's not normal. So if that's happening to you, it's not normal. But it's not a normal thing. So this reflex should be inhibited in a quadruped that's laying on its side. But obviously in this cat, it isn't. This cat's laying on his side, and that's a huge crossed extensor. You pinch the leg, you elicit withdrawal on the upper leg, and the lower leg shoots out. So that tells me this cat has an upper motor neuron lesion. So what about spinal palpation? When we are palpating the spine, we need to be very, very gentle. Remember, many of these patients are quite painful, and you can learn a lot from palpation by being very gentle. Now, if I'm palpating, I'm going to start, and because I also do chiropractic, I motion palpate, but I am touching every single vertebrae. And even if you haven't done any manipulation therapy and you've never taken that course, although it's a great course to learn, you can very gently palpate each individual vertebral unit, and you can take those dorsal spinous processes between your finger and move them back and forth. But you have to be very, very gentle. So I have listed here some very specifics for lumbosacral pain, for animals with lumbosacral pain. And the reason that I have that listed is because this is something that's frequently missed or not diagnosed. If your patient has pain on dorsal extension of the tail, I think we mostly know that, yeah, that could be lumbosacral disease. But what about pain on hip extension? Guess what? Also could be LS disease. And we have to differentiate that from ortho problems. Or pain on rectal palpation of the lumbosacral junction. So if you're not sure, you can put on a glove and you can palpate that rectally. Not really nice. Clients don't like it, but sometimes, if you cannot have an MRI done, you are able to get a diagnosis with that. So again, pain sensation is the most important clinical indicator for prognosis. And it's only necessary to test in paraplegic animals. If the animal is walking around, if it's not necessary, don't test it. They don't like to be pinched with forceps and things like that. And I'm generally using my fingers and pinching fairly hard with my nails. I'm going to get in an animal that is not pelagic, I'm going to get a response. If I don't get a response with my fingers, then I'm going to pick up a hemostat. So here's the thing. Loss of deep pain is the single most important clinical indicator for prognosis. And again, don't confuse it with withdrawal. And be very careful in dogs that are stoic, or dogs who are on analgesic, or those who are in shock or have decreased mentation. And always evaluate the unaffected limb to compare, because if it's a very stoic dog, you may not get any response on the unaffected limb. Or conversely, if it's a dog that hates its feet being touched, you may get the same response on both sides. So how do we recognize that an animal has spinal cord disease? Well, this is just clinical signs, right? They may have no gait abnormalities, but they may have spinal hyperesthesia, or they could have a combination of ataxia and paresis, and the paresis can progress to pelagia, and they can have bladder dysfunction. So they can have all of those signs, they can have one of those signs. The abnormalities that we see on the neuro exam generally are proprioceptive deficits, abnormal reflexes, spinal hyperesthesia may be present or it might be absent, and we may have decreased pain sensation. So how are we obtaining a neuroanatomical location? Well, this just shows us what we were already talking about, that C1 to C5 is upper motor neuron, this is upper motor neuron, this is lower, and this is lower, anything from here, back. So these are the areas that we are looking for. So we are doing our withdrawal test to help us know, and we're doing our crossed extensor, because those ones are very, very good. Obviously, if this part of the dog from here forward is normal, then we realize that the lesion has to be back here somewhere. But again, always check all limbs, because maybe the dog has Wobbler's disease and doesn't have any thoracic limb involvement just yet. So what do we see with our C1 to C5 spinal cord segment lesions? We can see tetraparesis or ataxia. Early, sometimes we only see ataxia in the back legs, but crossed extensor reflex, all four limbs, intact or increased spinal reflexes. Many of them have normal tone. If we have Horner's syndrome, that can be an issue. it's very uncommon to get tetraplegia. Often, all we see is pain with these animals who have neck problems, okay? But this is good with this cat. Spinal reflex is increased or intact. Spinal reflex is increased or intact here. So that's showing you what's going on here, what's going on here. Now, how about if it's C6 to T2? Well, C6 to T2, we very well may have conscious proprioception deficits in all limbs. We could have tetraparesis and ataxia. Often what we have is this: decreased thoracic spinal reflexes and intact pelvic limbs. Or we have muscle tone of the thoracic limbs is decreased and we're normal back here. So this is a good picture to look at. Decreased or intact, often they're decreased, and this can be increased, but a lot of times they're normal. And they can have that 2-engine gait or the disconnected gait that I showed you in that German Shepherd, possible for Horner syndrome, not likely to have tetraplegia, but it is common, or possible, but it's not common. So here we're going to look at this guy again because it was such a great picture. And here he is with his disconnected gait. See? Base-wide stance, pelvic limbs, shortened gait, thoracic limbs. Now, T3 to L3 spinal cord lesions. We have like this little dog. So this is your typical dachshund that's going to be normal in the front and have paresis and ataxia in the hind limbs. We will have crossed extensor reflex only in the back legs, and we can have increased or intact spinal reflexes, muscle tone, and bladder dysfunction. Upper motor neuron bladder dysfunction is very common. Now with L4 to S3, we have a spinal cord lesion where, the front limbs are pretty normal, but those back limbs are just not working very well. And there's a lot of loss of muscle tone, and really the biggest thing that we see is the tail tone can be flaccid, and sometimes there's decreased anal tone. So what do we do? In practice, we're looking at neurological or orthopedic. Proprioceptive deficits mean neurological disease. We need to decide if the front limbs or the back limbs are affected, or is it lumbosacral. And our spinal reflexes are going to help us. Do we have a 2-engine gait? So we need to look, do we have, something like Wobbler's disease? Do we have a T3L3 myelopathy? Do we have a brachial plexus problem? Do we have lower motor neuron paralysis? Do we have a 2-engine gait? What's going on? These are sort of how we look at this in practice. And so now that you've localized the lesion, let's say you have a T3 to L3 myelopathy, what do? Well, you're going to obtain a list of differentials and discuss the next step with your client. So this is just a quick little list that I have for you. Upper motor neuron versus lower motor neuron. There's lots fewer things on the upper motor neuron side, but disc disease, wobblers, discospondylitis, FCE, atlantoaxial instability, we see these all the time. On our lower motor neuron side, we have our neuromuscular disease like botulism and tic paralysis and polyradicular neuritis, and DM. DM is going to present for sure as a lower motor neuron disease. A lot of times LS disease, some discs, FCEs, wobblers, plexus problems. So we have a lot of things. So here's why do we care? Like, we just have a neurospinal. Okay, it's in the spine. Who cares where the lesion is, where it is? Well, the reason you care is because it changes the goal of the treatment. If it's upper motor neuron, we need to decrease the tone, decrease spasticity, work on that hypermetric gait and the atrophy. So we have to address the root of the problem. Lower motor neurons, we need to work on the origin and work on function. So origin and function, we can't just work on strengthening with these guys. They have no motor control. So we have to regain our motor control patterns. And in general, lower motor neuron lesions are more difficult to treat than upper motor neuron. So common neurological conditions, these are, again, what we're going to see. We're going to see them as acute and chronic. So as we put together these common neurological conditions, we're going to think, are they upper motor neuron, are they lower motor neuron? So this is just another table for you to think when you're figuring things out. And that's it for our part 1 of neurological rehabilitation.